Welcome to our class on flipping the classroom in regards to shock, myocardial infarction, abdominal aortic aneurysms, and hemodynamic monitoring. So we're going to go ahead and get started. So for our purposes today, we're going to start with shock. So shock is considered a situation that is very life-threatening. So it's a life-threatening concern, and all shocks are going to end in the same manner, with inadequate tissue perfusion and imbalance between cellular oxygen supply and demand. It just depends on the cause, how these will manifest in regards to whether or not the patient doesn't have enough volume aboard, whether the patient has a scenario where their heart isn't working effectively, or the volume is distributed through the body. So we'll talk about that as we go through, about the different types of shock and how they differ at getting to the end result of impaired or inadequate tissue perfusion and cellular metabolism. So we'll talk about that as we go on. Now, when we talk about shock, you've got to keep in mind that shock impacts all body systems. And when we have a patient in shock, we're really worried that they're going to start having organ failure. And it's not just one organ that typically fails, but multiple. That's referred to as multiple organ failure, multiple organ dysfunction syndrome. There, I got it. So we're going to talk about that and how our body will compensate for a state of shock. We do have compensatory mechanisms, and just like we talked about in the cardiac unit, our compensatory mechanisms don't always function for a long period of time, and that is true in shock too. So we'll talk a little bit about that and some of the interventions that we can do that are successful in reversing shock. So one concept that I want to discuss before we get into the different types, stages and types of shock is the concept of what problems or conditions can lead to oxygenation and tissue perfusion inadequacy. So if you think about your mean arterial pressure, if you don't remember what that is, your mean arterial pressure is the pressure that's sort of like a mean of your systolic and diastolic blood pressure. If you're not sure how to calculate that, most blood pressure cuffs machines do these days. You take the systolic and you add two diastolics to it, so systolic plus diastolic, and then you divide that by 3, and you can come up with your mean arterial pressure. So when we're talking about mean arterial pressure, we're concerned about those things that will influence it. So we already know that the amount of total blood volume will influence that. If we have too much, our mean arterial pressure is going to go up. If we don't have enough, our mean arterial pressure is going to go down. So total blood volume plays a role in oxygenation and tissue perfusion as it relates to the total blood volume. Next, our vascular bed plays an important role as well. So if we vasoconstrict our blood vessels, we're going to increase venous return, increase cardiac output, and increase mean arterial pressure. If we vasodilate them, we're going to have the opposite occur. So if we dilate the blood vessels, then we're going to have a scenario where our mean arterial pressure drops. So when we're talking about shock, there could be total blood volume problems, vascular bed problems, most specifically vasodilatation, or we can have cardiac output problems, such as in cardiogenic shock and obstructive shock. Again, we're really worried about those end organs, and the vital organs are the ones that we're most concerned about: the heart, the brain, the liver, and the pancreas. So we worry and watch for hypoxemia. Now this picture just gives you an idea of what I was just talking about more in a diagram format. And you can see the very first picture shows a normal blood volume and normal capillary size. And we have a normal mean arterial pressure in that scenario. The next one shows what happens if we increase the capillary bed. And when we do that, we're going to decrease mean arterial pressure. So there's an inverse relationship between the size of the vascular bed and the mean arterial pressure. If it goes up, mean arterial pressure goes down. If it goes down, mean arterial pressure goes up. And that's what you see in the third picture. As we go down further, the next one is a picture of what happens when we have decreased blood volume, but a normal capillary bed size. In this case, we're still going to see the decrease in mean arterial pressure. So when you're thinking about blood volume, when your blood volume's low, your mean arterial pressure is low. When it's high, your mean arterial pressure is high. The last one just depicts what would happen if we had both a vasodilatation and a lack of blood. In that scenario, it would really dramatically drop the patient's mean arterial pressure. So pathophysiology. The heart is always impacted in shock because, let's just go through these. Hypovolemic shock, we don't have enough circulating volume for the heart to pump out, so it affects the cardiovascular system. Then you look at the distributive shocks. In the distributive shocks, what's happening is the vascular bed is so dilated that there's not enough blood going back to the heart to meet the metabolic needs of the body. So, and anaphylactic shock, that's anaphylactic, neurogenic, and septic shock. In obstructive shock, something's squeezing the heart, like we've talked about cardiac tamponade already, squeezing the heart, and it's not allowing for the cardiovascular system to impact cardiac output. So if you want to kind of think of the heart as the end result of the impact of the shock, it surely is, and it begins there and ends there eventually in all shocks. We'll talk more about that as we go on. So blood volume, myocardial contractility. Blood volume would be your hypovolemic shock. Myocardial contractility would be your cardiogenic shock, and your constrictive or obstructive shock. Blood flow would be your distributive types of shock. And vascular resistance is the amount of pressure that the left ventricle has to overcome in order to get blood into the circulation. All right, so the different types of shocks, I've already mentioned. Hypovolemic, that's probably the one we all think of when we think about a patient in shock. So they just don't have the volume. So the volume's not there. It can be absolute or relative. So that can mean that they can bleed out somewhere like in their abdomen or bleed out onto the pavement, or they can do some shifting and different types of things within their body, like a shift from the intravascular space to the interstitial tissue, and you really can't see that as much. So we'll talk more about that when we get to hypovolemic shock. Cardiogenic shock, that's a pump failure. I always think of cardiogenic shock a lot like our car when our fuel pump goes out. When our fuel pump goes out, we can't go anywhere. So the same thing is true with cardiogenic shock. When our pump fails, we have backward movement of blood and no forward movement of oxygenated blood to meet the demands of the body. Obstructive cardiogenic shock can cause it. Obstructive is, let me back up there. Obstructive can be like a cardiac tamponade that we've talked about already, and a tension pneumo. You can see it with a pulmonary embolus as well. So something's just impacting the heart's ability to forward flow blood. So cardiogenic shock, the pump's not working. Destructive shock, it's kind of squeezing the heart so it can't go forward. Distributive shock, let's go to the next slide, because there's really three types of distributive shock. There is septic, and that's probably the most complex one we're going to talk about. Anaphylactic, you've had a little of that already in 271, so we'll expand on your knowledge of that. And neurogenic is probably the rarest type, and sometimes it's also referred to as spinal shock. All right, so let's go through the initial stages of shock, and we'll start with the initial stage of shock. When we're talking about shocks, initial is the first thing and probably the hardest one to kind of recognize with a patient. So we'll talk about its manifestations here. This picture is for your learning if you like these types of things, but I'm going to go ahead and click to the next slide with the information that I want to share specifically about initial stage of shock. So when we're talking about the initial stage of shock, it's very, very early, and the cardiac output and mean arterial pressure are decreased, and we will get a sympathetic response to sort of try to overcome that drop in cardiac output. That's the only compensatory mechanism we have in play at this point. So it's not enough to really see compensation going on. It may cause the heart rate to go up a little. It may cause the respirations to go up a little. And it may cause the blood pressure to change slightly. But sometimes it's really, really hard to recognize. The other thing that we see is we see the patient's blood pressure, specifically their diastolic blood pressure, increase slightly during this stage. But what you won't see in the initial stage is any signs of the renin, angiotensin, aldosterone system, which we'll talk about, which usually can be observed or assessed through urinary output. Okay, and we'll talk about that next. So a little diastolic blood pressure increased, the heart rate's up, but it's not abnormal yet. Respirations are increased a little, but still not normal. Okay, so I would say, in my experience, that initial stage is really hard to assess and determine. So you have to look at the risk factors. So if you know your patient just came back from surgery, had a total hip arthroplasty, and the OR nurse is telling you that the patient lost 500 mLs of blood, then you're going to probably watch that patient a little closer for these initial signs and contact the physician and say, you know, the heart rate's up a little, the patient's complaining of being really thirsty, the respirations are increased a little. Would you consider giving a fluid bolus and see if we can reverse some of those manifestations? All right, so let's talk a little bit about compensatory, or it's also referred to as non-progressive. So there's two names for this one. So non-progressive or compensatory. So the word compensatory I like better because it tells you exactly what's going on. So now we're reaching out to our anterior and posterior pituitary for some compensations and hoping, and our kidneys, our adrenal cortex. So we want a lot of help from a lot of our neuroendocrine processes to reverse the shock. So first of all, let's talk about what you expect in the compensatory stage of shock. In this stage, you would anticipate to see the heart rate above 100 and the respiratory rate above 20, cool and clammy skin, They're anxious, very anxious. Mean arterial pressure is dropping even more, 10 to 15. And then what we see is we see what we call a narrowing of the pulse pressure. So the diastolic blood pressure is going up and the systolic blood pressure is coming down. So there's very minimal space between those two. That's called a narrowing of the pulse pressure. Then we have baroreceptors in our central nervous system, and we count on the anterior pituitary and renal systems to help us. So let's talk how we do that. So first of all, the anterior pituitary is responsible for releasing ACTH, and that comes from our adrenal cortex, which then releases glucocorticoids or cortisol, and then we count on our adrenal medulla to release epi-norepi. So we're counting on those systems to come in during this stress and help us out. So all of those things are going to help us with the fight or flight process and dealing with this shock, as well as epi-norepi from the medulla. Remember, the cortex is on the outside of the adrenal gland, and inside is the medulla. The norepi and epi are going to cause some profound vasoconstriction. So they're going to do that in order to increase blood return to the heart. So in a case of shock, we're really hurting for cardiac output and blood coming back to the heart, and that's referred to as preload. So preload is the amount of blood in the ventricle at the time of ventricular contraction. So if we don't have the volume, or the volume is dispersed somewhere else, our preload's going to be low. So we'll need to go ahead and increase that through venous vasoconstriction. Now remember, preload, the way to think about that is that balloon, blowing up the balloon, you let go and you get a lot of pump or push across the room with it. So you want to think about that. So preload is the amount of stretch results in a greater contraction. So the more we blow that balloon up, the greater preload we have. So through vasoconstriction, we can increase that preload in the heart. We also want to increase contractility of the pump. That will help as well. So epi and norepi will help with that process, as well as dilating the coronary arteries. And we'll start shunting only to the vital organs, heart, brain, and away from the skin, GI, and kidneys. So this picture is quite complex, but I just point out a few things for you. Here's your hypothalamus up here, and your hypothalamus will influence the adrenal cortex and will provide for the release of renin, angiotensin from the adrenal cortex in order for the renin, angiotensin, aldosterone system to work. Over here you can see in the anterior pituitary, we count on the ACTH to release the glucocorticoids in the kidney as well in order to influence the fight or flight process. Then the renin angiotensin system, again, here is that, and that will vasoconstrict, and then the aldosterone in addition will help the process by retaining sodium in order to retain water and volume. And then you see up here ADH is released from the pituitary as well, but from the posterior pituitary in order to hold on to the volume and not allow us to urinate it out. So it's against diuresis hormone. So here it is in written format. It may be a little easier for you to understand than that busy diagram, but renin, angiotensin, aldosterone system. Okay, so we want that system working for us in order to vasoconstrict. We want that aldosterone in order to save the sodium and hold on to the water. And then in addition, we also count on if our PaO2 is low, there's chemoreceptors located in the aortic arch and carotid bodies, and that will increase respiratory rate to blow off some of that CO2, cause respiratory alkalosis, and impact the mental status change, and or may lead to some through the vasoconstriction of cerebral artery constriction. So in the compensation phase, we've got a lot of stuff going on. We've got vasoconstriction going on. We've got holding on to volume, either by holding on to sodium or just holding on to the volume and not letting the kidneys excrete it. So we've got a lot of stuff going on to try to compensate. Just like we talked about in our unit in the cardiovascular system on dysrhythmias, we can only compensate so long and then we're going to fail. So if a patient's in the compensatory stage, we really need to be aggressive with treating the shock and getting them reversed from their conditions so that they don't go into the next stage of shock. But as I mentioned earlier, thirst, anxiety, kidneys are retaining. Remember, urine output is a great sign that you have a patient going into the compensatory mechanisms, because your kidneys have initiated your renin, angiotensin, aldosterone system in order to hold on to volume and get volume back to the heart where it's needed. Okay? Our whole purpose during the compensatory phase is just to prevent end organ damage, so that's a real focus during that time. Progressive. Unfortunately, just like we said just a minute ago, our compensatory mechanisms do not last for long. So when they start to fail, then we're going to see a scenario where our patient goes into uncompensated state. We're going to see a more significant drop in their mean arterial pressure by 20 millimeters. And organ damage is evident and going to be noted. Lactic acidosis is getting worse. Hyperkalemia occurs, usually above 6 potassium. And we'll start to see cool, clammy skin, cyanosis of the fingertips, those types of things. So during this time of progressive shock, we really want to protect all organs, but the ones that we see start to fail most frequently, the kidneys. We can have GI ischemia, bowel and liver dysfunction or ischemia. We can see that ARDS that we talked about a couple classes ago, confusion, delirium, coma, so that's the reaction to the brain as a response to the progressive shock. Lactic acidosis can build up, as well as toxic metabolites. Cardiac ischemia, you can see some decreased contractility. We'll get to that again when we get to septic shock, so we'll talk about that more in that unit. So we really need to correct or reverse what's causing the hypoxemia and the circulatory problem at this point, or it is cancel Christmas time. Okay, so refractory shock is typically irreversible and organs are unable to recover, and once a patient goes into multi-organ dysfunction syndrome, which is 2 or more organs fail, could be any of those that we saw on the last page, or it can also be a blood a blood problem or hematological problem called DIC, disseminated intravascular coagulation. Typically when they get to that point, it's hard to get them out of that. So those are the stages of shock, with the first one being very hard to notice, and the last one being impossible to reverse. So we're going to go ahead and talk a little bit about the different types of shock. This picture you may like or you may not, but if you do, use it. If not, I'm just going to skip on past it. The next few slides just pretty much highlight what you already know. You guys are smart and have learned this, but when we're talking about shock, it talks to you about the most sensitive early indicator is central nervous system change, so restlessness, agitation, anxiety, those types of things. Confusion, coma is late. Okay, and then if you continue on, we already talked about what happens with the blood pressure and the pulses, and the renal, decreased urine output, increased specific gravity, sugar and acetone may be present in the urine, and cool, clammy, mottled, cyanotic for the integumentary system. And remember, blood shunted away from the GI system, so that's probably one that you'll see early. Changes in bowel sounds and motility, nausea, vomiting, and constipation. All right, so let's talk about cardiogenic shock, one of my favorite. So when we're talking about cardiogenic shock, I just experienced a major myocardial infarction. That will lead me into cardiogenic shock. If I cause necrosis to my left anterior portion of my left ventricle, I will definitely experience cardiogenic shock. So when we're thinking about cardiogenic shock, there's a great big decrease in cardiac output, and afterload is increased. And so let's talk about afterload just for a second. Afterload is the pressure at which the left ventricle has to pump against in order to get the blood out of the aorta and into circulation. So we talked about preload being blowing that balloon up. The greater you blow it up, the greater the contraction. Afterload is putting a knot in that balloon and then trying to get the air out of the balloon. So that's a way to think about it. Another way that I've heard it explained is that afterload is like trying to push a door open on a really windy day against the wind. So you're trying to push the door open, you can't get it open. That would be a case of afterload, increased afterload, okay? So those two situations can lead to a very reduced mean arterial pressure, reduced cardiac output. PVR stands for peripheral vascular resistance, which systemic and peripheral are they're the same concept. Peripheral just means it's not getting out to the periphery. So I said MI can cause cardiogenic shock. So can dysrhythmias, heart failure, structure defects, such as like aortic stenosis or a septal defect. So those can all cause it. You remember in the beginning I said that all the shocks end the same, but how they get there is different. This depicts that for you. You can see with cardiogenic shock, the cause may be a primary ventricular ischemia, so like a MI. It could be like a structural problem such as aortic stenosis, or it can be a dysrhythmia. And any of those can lead to ineffective forward movement of blood. And when you have that, if it's related to ischemia, you're going to decrease your stroke volume. And you remember, cardiac output is stroke volume times heart rate equals cardiac output. So you're going to decrease that as well. If it's more of a dysrhythmia, then the ventricle's not going to be able to empty. There's going to be increased pressure in the pulmonary arteries and pulmonary edema, so it's going to back up into the lungs and decrease oxygenation. So it's just two different paths that they take, but as you can see, ineffective tissue perfusion and impaired cellular metabolism is the end result. You'll see that with all the shocks today. All right, so when we're thinking about a patient that presents with cardiogenic shock, they are going to have an increased heart rate, increased systemic vascular resistance or afterload, a decreased cardiac output or preload, decreased urine output, cool, clammy skin, restless, anxious, confused. But the main thing that's really different with a patient in cardiogenic shock is you're going to hear crackles in the lungs. This is something you will not see in any other type of shock except for one that we're going to talk about, and that is obstructive shock. So this type of shock is kind of different than we think of as a traditional shock, because our patient actually is going to look like they're a fluid volume overload patient, but they're really in a cardiogenic shock. So they may appear as if they have a lot of volume aboard. They may have some edema, chest discomfort, because if the pump isn't able to pump forward to deliver blood to the body, it's not going to be able to deliver blood to the myocardium as well. So chest pain can occur. All right, so when we're thinking about caring for these patients in cardiogenic shock, there's really four major priorities. We want to limit myocardial oxygen demand, so arresting the patient, making sure that they're not anxious, that they're nice and calm, make sure that they're not straining when they have a bowel movement, those types of things. We want to enhance myocardial oxygen supply, so giving them oxygen. We may need to give that to them, through a nasal cannula, a mask, or we may, need to put them on a ventilator and give it to them that way with some PEEP. We may need to also think about other ways to get oxygen to the myocardium. We may need to bypass the heart circulation and allow the ECMO or extracorporeal circulation machine, like a heart-lung machine, to take over for a while, or maybe an intra-aortic balloon pump. We want to keep them comfortable and relaxed and, not anxious. We want to do that and just watch them for complications. Our main concern in cardiogenic shock is it's going to lead to MODS, multi-organ dysfunction syndrome. So that's what we're really concerned about. So when we're talking about treatment, what we're going to do for these patients, like we already said, decrease their anxiety, keep them comfortable. If they have any type of dysrhythmias, we're going to go ahead and treat those. So we're going to want to take care of those with the drugs that we talked about last time. Then in regards to treating the cause, if they have, let's say they have aortic stenosis that's leading to our cardiogenic shock, or they have 100% occluded coronary vessel, then we would do the surgical procedure that would reverse that situation. If they're having a hard time controlling the patient's oxygen, they can even use CPAP or a BiPAP or something like that. In addition, we already talked about preload, and they will need to go ahead and reverse that. So first of all, let's assess for it, and then we'll talk about how we're going to reverse that. So when we're talking about preload, this fellow in this picture has a real distended neck vein. So it's obvious that he has distended neck vein, and he's at a 30-degree angle, so that's how we would assess that. that would tell us that his preload's increased. Now, for our purposes, I'm going to explain what CVP and PA catheters are, but we're not going to go into great detail on that. So, CVP is right-sided pressure, so it measures right arterial pressure, so that measures right arterial pressure, and a PA catheter measures left-sided pressures, or left ventricular and diastolic pressures. Now, I'm not going to test you on that, and it's not going to be on NCLEX, but I do think it's important because the book talks about it quite a bit, that you know what those two are. And we'll discuss it again a little later in this presentation. The other thing is INO, watching that, making sure the intake matches the output, maybe restricting fluid, those types of things, giving them some Lasix as well, or some type of diuretic. Weight, they're probably going to increase in weight. Edema, and chest x-ray to determine if they have any type of infiltrates is another thing that you're going to do. So then we want to make sure that afterload, remember that pressure you have to push against to get out the door, is reversed. So if we maintain their blood pressure, that helps reverse that, because that does cause a lot of vascular resistance, high blood pressure. And we can also give a drug called nitroprusside. Nitroprusside is also called nipride, and that drug can be used as well. It is a vasodilator, so you want to think that it's going to lower the patient's blood pressure, so you'd be concerned that it may go too low. And then increased contractility, inotropic drugs are great, but you got to remember they're also going to increase oxygen demand to the myocardium, so you get a little concerned about that. I've already asked you to know dopamine and dobutamine, so I won't add any more to that, so don't worry about the milrinone. Here's just that list again for you, just so that you know. Remember, on this list, I ask you to know dopamine, epinephrine, Levophed, dobutamine, and then we just added nitroprusside, just to know that that's a vasodilator. It's going to lower the blood pressure, okay? I don't know why I put that in there twice. And then here are just some common drugs used for a patient with a cardiovascular problem, such as heart failure, cardiac tamponade, or cardiogenic shock. Sorry. Okay, so then I already talked about these devices, but these are some of the devices that can be used, and they include intra or aortic balloon pump. I mentioned that earlier. That can be used in an intensive care unit. Surgically, an Impella left ventricular assist device and a traditional left ventricular assist device can be inserted into the patient surgically, and ECMO is your heart-lung machine or your extracorporeal circulation. All right. So that leads us to hypovolemic shock. So let's talk about that. Like I said earlier, I think this is the one that we think of most when we think of shock. So I have some type of trauma and I bleed out, or I had a GI bleed, or I had an aneurysm rupture, or something like that. That's what we think about when we think about hypovolemic shock. Now, if a patient has trauma or pancreatitis, sometimes they'll develop other signs that we look for. And one is Grace Turner's sign, which is a bruising or a discoloration on the flank area. So on the flank area. And then the Cohen sign is a bruising or discoloration that is peri-umbilical, around the umbilicus. So we look for those two things. Other ways we can lose volume is through sweating, exercise, if your thirst mechanism isn't telling you to drink. Very old, very young, that's more of a problem. Or we lose volume through vomiting, diarrhea, drains, NG tube, third spacing, such as in burns. We'll see that in 3 times a semester third spacing in which the fluid shifts from the intravascular space into the interstitial tissue. We will see that with burns, acute pancreatitis, and peritonitis. So we'll talk about those. Again, here's our diagram that ends in ineffective tissue perfusion and impaired cellular metabolism. So whether it be relative, something we can't see, that's how I think of it, or absolute, something that we know they bled into their gut. We're decreasing circulatory volume, venous return, stroke volume, cardiac output. So it all leads the same way. It's just the cause that's different. Whereas in cardiogenic shock, it was pump failure. Here, it's volume failure. So our problem is a volume failure scenario. So typically, you have to lose about 20 to 30% of your volume in order to go into hypovolemic shock. And initially you may see some capillary refill that's noted at 10%. So a delay in that. Decreased SATs, pale, clammy skin, pulses decreased, and that's peripheral pulses are decreased. The heart rate would still go up. Anxiety, confusion, lethargy, and hemoglobin, if we know that we've automatically lost the volume, it's going to be down. But if we have a scenario where our patient has actually shifted their volume, like from the intravascular space to the interstitial tissue, then we're going to see a scenario where the hemoglobin hematocrit go up. Because what we've done in that scenario is we've pulled out all of the fluid part of the blood and left the red blood cells, platelets, white blood cells behind. And so the red blood cells will be increased, hence leading to elevated H&H. So when we're talking about hypovolemic shock, chest, they may have a contusion of the lung, leading to decreased breath sounds. Abdomen, they may have distension of the abdomen. A thigh, fracture of the femur. Got an interesting story about that. My son was 10, and it was the first day back from Christmas break, and he was going down, he's jumping off a snowbank, and he fell, and he was laying on the ground and wouldn't get up until I came to see him. When I did, he said his leg hurt, and I rubbed it, and he said it felt better. So I put him in the car, and I drove him home. And when we got home, I looked in the rearview mirror at him before I went to get him out of the car, and he was white as a sheet. So I reversed the car, went to the emergency room, and when we got his snow pants off, his femur was broken in two, and he ended up having to have skeletal traction, and then he had rods in his femur for 6 months in a wheelchair. So they really do bleed out. The other one that bleeds out really bad is a pelvic fracture. They bleed out really, really bad. My husband bled out really bad, and his hemoglobin was down in the 7s when he was in the hospital with his accident. So here we already talked about the hemoglobin hematocrit. You can see that the potassium goes up, lactate goes up, lactate or lactic acidosis. And then, as you can see, the main acid-base imbalance we worry about is respiratory acidosis. So when we're thinking about our patients with hypovolemic shock, the main thing that we need to do is replenish fluids. Whether it shifted into the interstitial space or they lost it by bleeding out on the pavement, we got to replace the volume that they've lost. So, and in consideration of the last slide, when we said that these patients are in respiratory acidosis, the most common fluid that we see used for a patient in hypovolemic shock is lactated ringers. So we use lactated ringers. Colloids are what we call plasma expanders, so they kind of make the plasma seem more voluminous. So those can be used also to bring the blood pressure up. Blood products can be given to red blood cells. fresh frozen plasma, platelets, the rest on that list except for autotransfusion. If we know that they have a bleeding condition that has led to their hypovolemic shock, we can use those for that. Okay, so besides the volume, which is our first go-to as far as that, you can put oxygen on these patients too. You need to put oxygen on these patients to increase their oxygen carrying capacity. So that's important. But you want to treat the cause, stop the bleeding, so put pressure on it, whatever you have to do to get it stopped. They may have to go to surgery to control the bleeding, so that may be an option as well. If the pressure is still low, then we can use some vasopressors such as norepinephrine and dopamine that we talked about last class. I'm going to ask you not to worry about neosynephrine, so that one you're not going to worry about. And then dobutamine we did, and miloronin, we already said that I'm not going to make you responsible for that. Again, the table's there for you, so you have it available as you study. We already said oxygen, so oxygen, start 2 large peripheral IV lines. A central line would be preferable. We may need an intra-arterial blood pressure monitor. We'll talk about that a little later, along with a CVP. Okay? So remember, our patient in hypovolemic shock is going to go through those stages. So when you start seeing the urine output drop and their heart rate go up, then you know that the patient's in non-progressive shock, and you got to act quickly so they don't go into progressive shock. So this is a chart that identifies for you best practice related to hypovolemic shock. So researchers have found that the best way to treat hypovolemic shock is to make sure that you have a patent airway, get IV started with fluid, administer oxygen. We don't place the patient in a Trendelenburg position anymore. We are going to put them flat with their head of the bed elevated to a 30-degree angle. And we're going to examine them for any signs of obvious bleeding. Administer drugs. If we need vasopressors, we can give those. Increase the IV fluid delivery. And don't leave the patient, so stay with them. I don't know how you guys feel about concept maps, but I think this one is a very thorough job of discussing a patient and then looking at what you expect as outcomes, and then what is it that you're going to do for this patient. So it's all on one sheet. So if you find that helpful, it is here. Deanne Blanc, I always call her Dina, put this together, and she's a speaker and educator. So if you like it, that's great. If you don't, that's fine. All right, we're going to move on and talk a little bit about distributive shocks. And distributive is just the category, and under the category is neurogenic, septic, and anaphylactic shock. All 3 of those are considered a distributive shock. And the best way to remember this is it's a vasodilatation. So all 3 of them, for 3 different pathophysiological reasons, result in the vascular bed being vasodilated, that results in a patient losing volume through vasodilatation and decreased return to the heart. So distributive shocks, neural-induced, we already said that it's a loss of sympathetic tone, so you know that already. But neural-induced, probably the neurogenic shock, the most frequent one that I know of, is spinal cord injuries. You can see it in head trauma too, but I've never seen it with stress, anesthesia, or pain. All right, so the three types that we're going to talk about: anaphylactic, sepsis, and we won't get into capillary leak syndrome. Okay, so anaphylaxis, so neurogenic anaphylaxis and sepsis. So we'll start with the one that is probably the least common, and you really, really don't. There's not a lot to know about this, and it's pretty rare. So, and that is neurogenic. So neurogenic occurs when a patient loses the sympathetic tone, and that results in vasodilatation, and then the heart's not getting what they need, and then there's not perfusion to the organs. So basically, the big difference with this one that you want to keep in mind is it doesn't present like the others, and that this is the only one you won't have tachycardia with. So you have bradycardia in this one, warm and dry, and hypotensive. Okay. They tend to also, it says warm and dry on that slide, but you may read in the book that, and it says it here too, that sometimes they lose heat through the vasodilated skin, and so they take on the temperature of their environment, so they could be hypothermic as well. Okay, so just to keep that in mind. But the slow heart rate is the one thing that you want to keep in mind that's different in this one. And that with the slow heart rate, you may actually even need to give some atropine. Okay? So you may have to treat hypothermia in some cases. You may need to give fluid and vasopressors with this, and then atropine for bradycardia. Again, here's that picture showing up. So you can see the whole result of this one is loss of vascular tone, which causes vasodilatation, which decreases the return to the heart, which decreases stroke volume, cardiac output, and, of course, tissue perfusion and cellular metabolism. And you can see bradycardia also further decreases cardiac output. So, pretty simple one to keep in mind. Okay. So now let's talk about anaphylaxis. I know you talked about this in Nursing 271, but it's an antigen-antibody reaction. Okay, most commonly caused by food, can be drugs, bite or a sting or a chemical. Okay, so we're always on the look for this. I know in Nursing 271, I think you had anaphylaxis related to blood transfusion reactions. So this one's a little busier because you have a lot of things going on, mediators swirling around, little peripheral vasodilatation, increased capillary permeability, constriction, so bronchoconstriction, laryngeal edema, stridor again, like we talked about, decreased oxygen, and then decreased circulating volume, decreased venous return, stroke volume, cardiac output, leading, behold, to the same things we've talked about in the other shocks: ineffective tissue perfusion and impaired cellular metabolism. So when we're thinking about this, some of the things that I kind of keep in the back of my mind about anaphylaxis is a patient may feel like there's a lump in the back of their throat. They have the stridor, maybe they're hoarse, wheezes, rails, which are crackles these days, and rhonchi. And the other thing that they develop, maybe some difficulty swallowing, maybe some GI disturbance. They may have that. But the real thing that I think of is angioedema. When they develop edema, the picture to the right is a case of angioedema of the face, secondary to an anaphylactic response. They may get itching, redness, urticaria, so they may develop all of that in the area. So they may develop that as well. And then they're restless, uneasy, apprehension. They feel like something bad's going to happen, so that's something to keep in mind. And just to keep in mind that not always are people have a reaction on the first time they're exposed to an allergen. It's typically delayed, so it occurs in consequence or other episodes of exposure to that allergen. So remove the allergen, whatever it is, like in the blood transfusion reaction sim. I know you all stop the blood to remove that. Protect the airway and secure the IV, because you're going to need to give some IV medication, so you want to be ready for that. Speaking of that, what kind of drugs do you think that we're going to give? Epinephrine, probably the number one drug of choice in most instances, given IV in real severe cases. I'm not so concerned that you know the doses of that, so that's not real important. Benadryl, another drug of choice that can be given IV as well, and corticosteroids can be used in this scenario as well. Again, to counteract the distributive portion of the shock, we can give crystalloids or colloids, so we can give those. We can give inotropic agents, vasoconstrictor agents may be necessary as well. So we can give epinephrine, we can norepi, we can give, which is Levophed, dopamine, or dobutamine. So we can give those drugs. All right, we got to our most concerning type of shock, or not concerning, I would say our most complicated type of shock, and that is septic shock. So I'm going to go through that for you. We're going to start by talking about what happens in septic shock. So in septic shock, we have a scenario where a patient has some type of blood infection, or some type of infection that seeds into the bloodstream, and with that comes a systemic inflammatory response. So with that comes a systemic inflammatory response. And so they have an infection, they develop it in the system or in the blood, and then they develop sepsis. Okay. So what I want you to say, first of all, is with sepsis, there are three distinct stages. Remember I told you that earlier. There's stages overall of shock, and then there's stages of septic shock. So septic patients can go through initial, non-progressive, progressive, and what's the last one? Irreversible. No, that's not right. Refractory. That's it. So they can go through that, but they have their own stages as well. So we'll talk about this in more detail here in just a minute, but I just want to point out a couple things for you. There's three phases. This is early shock, and sometimes this is considered cold shock, and I'll explain as we go on. But what we're going to see is we're going to see the decreased cardiac output. We're going to see decreased stroke volume. We're going to see the lactate start to go up. We're going to see the blood sugar start to respond due to the release of cortisol. But we're going to see the SAT sitting kind of below 95, which isn't really great. Okay? So that's cold shock. And I'll go back through this in just a minute. Late sepsis is considered warm shock. So let's take a peek and see what's happening. Our cardiac output is increased. Our stroke volume is increased. Whoa, we're doing a good job with our patient, right? We're getting them better, it looks like. But now let's get down here to our lactate. It's increasing. It should be below 2, and now it's 2 to 4. Okay, and then what's happening with our blood sugar? That's going up more too. And now look at this saturation, down to 85%. So this is warm shock. We sometimes call this the calm before the storm, because we see this just before a patient goes into septic shock. Okay? So I call this cold shock in early sepsis, warm shock in late sepsis, and this is cold shock as well in septic shock. And I'll explain a little bit more here in a minute. So with this, the cardiac output is greatly decreased. The stroke volume is greatly decreased. Our serum lactate is through the roof. Our glucose is higher than ever, and our SAT's lower than ever. So with this sequel of events, what I want you to kind of think about with septic shock, what happens is just like in initial shock, which remember septic shock patients can go through those stages too, but they're going to look a little abnormal here. So in this cold shock, they're going to look a little abnormal with a little decreased, but not really terribly bad. But then they give you this little glimpse of them getting better. And you're thinking, and I've done this too, where, oh yeah, my patient's getting better. But sometimes it's the calm right before the storm. So it could be that they're going to get worse. I'll give you an example. One day I was working in our ICU, and I came on for a 4-hour shift. And this elderly lady was my patient, and she came in with sepsis, rule out sepsis, and she had a septic hip. She had had arthroplasty and had a septic hip. While I was there, she had already went into early sepsis, or the first cold shock, and her blood pressure was decreased, and we treated it with Valium, and then the doctor decided to put her on a vasopressor, and we had her on that. And then she started looking better. So all of a sudden her blood pressure got a little better, and she looked a little better. But then within that 4-hour period, the next thing I know, her blood pressure's greatly decreased. She's looking worse. And I noticed that her central line is bleeding. Well, she went into disseminated intravascular coagulation during that time. So she went into disseminated intravascular coagulation, and I thought she probably died, but I found out later, I saw her in the elevator one day, she didn't make it, so I was super excited to see that. But that's what I want you to kind of think about. You got to really watch these patients really closely. So gram-negative, probably the most common that we see. I don't think it's really important that you know who's causing it, just to know that when a patient develops it, we have to survey these patients for risk factors, and we've got to treat them aggressively if they have it. So SIRS. SIRS is called the Systemic Inflammatory Response Syndrome. And what this is, it's an inflammatory response that occurs related to the microorganism gaining access into the blood. So as the blood is infected, you're going to see these types of responses. You're going to see altered capillary endothelium, so it's going to damage the inner layer of the capillaries. It's going to impair vasoregulation, and nitric oxide is increased in this, and that leads to the vasodilatation, hence the septic shock, which is a distributive type of shock. There are releases of inflammatory cells, neutrophils, macrophages, mediators, and then activated protein C is decreased in response to SIRS, and that's what leads to our DIC. So what happens is we have all these microthrombi that develop all over in our body. They cause ischemia to end organs wherever it is, hands, feet, gut, and all the clotting factors are used up, creating all these microthrombi, and then we don't have any, and then we bleed. So these patients, they clot first, become ischemic, and then they bleed out second, and further the ischemia problem. So that's just something to keep in mind. So what you see on this slide is the fact that sepsis and really profound hypotension can lead to septic shock. So usually when it's very profound, then we think about this. What this criteria is on this page is the SIRS criteria. So when a patient has a temperature that's high or low, heart rate's high, mean arterial pressure is low, respiratory rate is low, O2 sat is low. When all these things are occurring, then we're going to categorize this patient as being at risk for septic shock. And so then we have criteria of WBC. So if they're high or low, or a shift to the left, and the shift to the left means that you have more immature white blood cells. So you have more bands, which are immature, than you do segs, which are the mature white blood cells. Dyspnea, anxiety, renal insufficiency, and decreased urine output. So these are the signs that we're looking at that are precursors to septic shock, that we would then say, okay, this patient's at risk because they're showing signs. We're going to kind of halt this in its tracks by taking certain interventions or actions with the patient. So we'll talk about that as we go on. So remember I said early sepsis, they look kind of, cool, their cardiac output's low. Then we get into late sepsis, they're the warm shock. Patient's warm, the cardiac output is high, they have a fever, their white blood cells maybe even normal, elevated or normal, and their mean arterial pressure is acceptable. So you're thinking, my day is done, I can go home now, I saved this patient. But you may not have. It just may be that calm before the storm. Okay? So just consider that. So septic shock. When we step into septic shock, you want to think about the sickest patient that you possibly could ever see. So this is the patient's going to have probably low WBCs, high bands, cardiac output is low. Remember earlier I said I get back to what happens to the heart in septic shock. Well, what happens in septic shock is the myocardial can't compress as well because a myocardial depressant factor is released and from the pancreas, and this further decreases the mean arterial pressure. So these patients are very hemodynamically unstable. Okay? Now remember we talked about cold shock and warm shock, or cool shock and warm shock, however you want to say it. But that's also referred to as a hypodynamic state. So some of the books call when the cardiac output is low, a hypodynamic state. And then when they're in that warm shock, that's a hyperdynamic state. So the way I consider it is in early shock, they're in hypodynamic. In late, they're in hyperdynamic. And then in septic shock, it's severely hypodynamic. So that's just a way to think of it. I already mentioned that the patient goes into DIC in septic shock, so we're watching, surveying them for that. So my patient that started bleeding from her central line was going into DIC, which told me she was in septic shock at that moment. So then we had to intervene. We were able to get her pretty much stabilized within the next few hours. So that's something. So then if a patient's in septic shock, you're thinking DIC, watch for that. ARDS, look for that. Are they going into refractory hypoxemia? That type of stuff. Then you got to consider your populations and who's at risk for developing this. So you got to kind of think at the elderly, immunocompromised, or patient that maybe had a transplant that's on autoimmune drugs to prevent the rejection of the organ, those types of patients, invasive procedures, and so forth. Now this picture was in your book. It just kind of explains how the event occurs with sepsis. First, they get a local infection. Then they get a systemic infection. Then SIRS occurs. Then they get severe sepsis, start to maybe have one organ failure. And then they go into septic shock. They get ARDS, they get DIC, and if we don't treat it, then they're going to die. Just another picture, a little busier, but a couple things I want to point out. Here's your bacteria up here, and then just the two different, I don't think it really matters. But here's some of the pathophysiology that occurs. It affects the complement system, coagulation, kinin system, neutrophils, so all of that, and a lot of inflammation. There's your nitric oxide that increases. Then you have capillary refills, or capillary leak, excuse me. So you have an increased capillary permeability and the fluids leaking out. You have the thrombi from the actual lack of activated protein C and the development of DIC, cell adhesions, free radical damage. So all of this, tissue hypoxia, apoptosis, so all of that's going on and will lead to multi-organ dysfunction. Here's another picture like the others that we have, and this one's much busier because there's a lot more pathophysiology going on. So you can see in myocardial depressant we already talked about. We talked about the endothelial damage, activation of the central nervous system and endocrine. So we're hypermetabolic here, impaired cellular oxygen demand. Here's our microthrombi, increased capillary permeability, peripheral vasodilatation, some selective vasoconstriction, and then it's just going to maldistribute the blood in areas that it's not needed. And then you're going to have ineffective tissue perfusion, impaired cellular metabolism. Just another view of that. So I put them in. Some are helpful, some are not. So let's take a second and talk about MODS. It's relatively simple. It just means that more than one organ fails. So it can be like the lungs, the heart, the kidneys. Lungs would be ARDS. Kidneys would be acute tubular necrosis leading to acute renal failure, or acute kidney injury these days is called. And it can also be the hematological result of DIC that we already talked about. So here they are: liver, GI, renal failure, cardiac depression because of that myocardial depressant factor, DIC, we already talked about ARDS. So when we're talking about managing sepsis, it's going to be really, really important to treat that infection with the known antidote. So you want to have blood cultures done so you know what's going to be most effective for that patient. Maintain oxygenation, nutritional support, provide individual organ support so they don't fail. So when you have a patient with septic shock, there are specific, or at risk for septic shock, there are specific things as a nurse that we are to do for the patient. And first of all, identification early is really, really important. So we want to make sure that we're watching for categorizing those patients that are risk for, and make sure we're watching them very, very carefully for signs of sepsis. And those criteria I provided earlier. Administer fluids, so fluids do help. We're also going to give vasoactive drugs if we need to. They're going to be transferred to an ICU, kept comfortable, as far as comfort and emotional support, and just survey them for any organ shutting down. Now, septic shock management, there are national guidelines called the Surviving Sepsis Guidelines, and Iggy's book, she refers to it as the sepsis resuscitation bundle. So with that, there's specific things. Anyone that meets those SIRS criteria, there's certain things we're going to do for them. So we're going to do lactate levels. We're going to administer antibiotics. We're going to go ahead and watch the lactate levels. We're going to deliver fluids. We're going to maintain their mean arterial pressure at least 65. We're going to monitor them for hypotension. So there's certain things that we're going to do specifically for this patient. In addition, we're going to provide the patient with low-dose steroids in order to support their immune function, or their endocrine function, excuse me. So we're going to do that. We're also going to administer, keep an eye on that blood sugar and keep that controlled with insulin, and maybe even put them on a mechanical ventilator, prevent deep vein thrombosis during this time with the stasis of the blood. So those are all things that we're going to be doing. Now, Xigris was a drug that was on the market. It has since been removed, and it was an activated protein C drug, and it was $7,000 a dose, and it was not effective or had side effects that warranted taking it off the market. And then there's your hydrocortisone that you would use to support the endocrine or adrenal insufficiency, and then the insulin drip as well. All right, so if you have questions, bring them on septic shock. That's probably the most complicated one we're going to talk about, but that's a good start for you with information. So obstructive, now this is pretty easy because, okay, something's causing the heart not to be able to contract, either PE, cardiac tamponade, a tension pneumo. So with that, then we're going to want to just go ahead and relieve whatever the cause is. So with that, we're going to go ahead and relieve it. So if it's a PE, treat it with anticoagulants, maybe embolectomy, tamponade, pericardiocentesis, tension pneumo, do a needle compression, chest tube type scenario. So here's the sequelae of events that occur with obstructive shock. First, you have impaired diastolic filling, increased right ventricular afterload you can have as well, increased left ventricular afterload, so right ventricular and left ventricular, and all of that's just going to obstruct the ability of cardiac output and lead to decreased tissue perfusion and impaired cellular metabolism. So obstructive shock, you're just going to, treat whatever's causing it. So you're going to treat whatever's causing it, and that will reverse it. All right, so we got a couple more things to talk about. We're going to talk about myocardial infarctions. And myocardial infarctions, as you know, is necrosis of the heart itself due to lack of oxygenation to the heart through the coronary arteries. So let's get started and talk about this. We're going to talk about the coronary arteries first. And if you kind of think about the heart as right and left, we have two main arteries. We have the left and the right. And the left main artery divides in two branches. And that is the left anterior descending and the left circumflex artery. Okay? The left main is often referred to as a widowmaker because if you occlude your left main, you're going to cause necrosis of the entire left ventricle, and those patients usually die at the time of their infarction. Left anterior branch descends towards the anterior wall of the apex of the left ventricle, and it supplies blood to the left ventricle, the ventricular septum, and and the chordate tendineae, they are what holds or allows for the valves to open and close. Papillary muscles are part of the valves as well, and the right ventricle. So our left anterior descending does a lot of work, and it is one that is common. Probably 25% of MIs occur in the left anterior descending. Now the left circumflex descends toward the left lateral wall of the left ventricle and the apex. So that's where it's heading. So left atrium, lateral wall, posterior surface of the left ventricle are all supplied oxygen by the left circumflex artery. The right coronary comes up from the right sinus of Valsalva and encircles the heart and then descends toward the apex of the right ventricle. Now the right coronary artery results in an inferior MI. Remember in our class, our class activity, we had a patient who had an inferior MI that was in sinus bradycardia. So in a right coronary artery MI leads to an inferior MI, you can see bradycardia. Okay, so let's take a picture. No, we won't take. We'll look at the picture. How about that? Sounds better. Okay, so here's your left main right here. That's the widowmaker. Okay, here's your left anterior descending that comes down here. Takes care of a lot of the surface of the left ventricle. Here's your left circumflex. We could turn the heart around and see it back there, but it goes back there. And then here's your right coronary, and it comes down here, and if you had an inferior MI, it would be down here. Okay. So you guys know this already, cardiac output, heart rate times stroke volume. Okay, we've talked about that already on this slide presentation. I left it in there just in case. So you know stroke volume is the amount that of blood that's ejected with every beat. And you know what systemic vascular resistance is now. Trying to push that door open against the wind or trying to get the air out of the balloon with a knot. So that really stresses the heart significantly and can be a culprit that leads to a patient having a myocardial infarction. Preload, remember that's Frank Starling's law. The greater the stretch, the greater the contraction, within limits, right? Because eventually it's going to stretch out. All of us are going to have heart failure if we live long enough. It's just a matter of life. And then afterload, resistance, that the heart, so now the left ventricle is full. What is that resistance, that systemic vascular resistance it has to overcome to get the blood out of the ventricle? Just a picture of preload, afterload. So that's something that if it helps you, it's there for you. This one too, just talking about influences on cardiac output. All right, so labs, really important labs. Lipids, of course, are going to show us patients that are at risk for developing an MI, so they're going to give us an idea if the risk is there. Urinalysis, anytime you have heart disease, you have kidney disease. So we're always looking at the kidneys as well. And then some of the enzymes, CKMB, troponin, and TNI and TNT are the two common ones. We don't do myoglobins anymore. So CKMB, that was, that was something that we had in the simulation. I think I'm probably giving that away for people that haven't been in there. Whoops. So if it's elevated, it's going to indicate that some myocardial injury has occurred. Okay. I don't see that one done as much anymore, and CK is the overall enzyme, and if that's 0, that's normal. The one I see more is troponin T and I. So these numbers I will have you memorize and know because you may see them on the test. So they're very useful. They're very specific to ischemic myocardium and are used. The great thing about the TNI and TNT is that they start appearing in the blood 3 to 5 hours after the myocardial infarction, and they stay elevated for 7 to 10 days for those patients who think they're just having a little indigestion and it's been going on for a week. We can still see an elevation in those patients. So, myoglobin, not used, it's the earliest indicator, but it's not specific to myocardial damage. And these are some that can tell you that a patient's at risk. So BNP, homocysteine, CRP, microalbuminuria. You like how I said that? And then lipoprotein A. Those are all going to give you an idea that a patient is at risk for developing heart disease. So EKG. EKG is going to be very helpful in myocardial determination, in that if a patient has any type of ischemia, we're going to see an ST segment depression. If they have any type of elevation, a STEMI, ST segment elevation, then we're going to see that our patient is experiencing a myocardial infarction or has experienced. The other thing you want to think about is with patient, there's also a type of MI called a Q-wave MI, and that's a transmural MI. It happens through all 3 layers, the endocardium, myocardium, and pericardium. And once a patient, and it's manifested by a wide, deep Q wave, and once they have that, they will have that deep Q wave for the rest of their life. Okay, so stress test. Stress test is a way that we can determine that our patient is having some significant ischemia with exercise. So a stress test typically has 2 different parts. One is where they either put them on a treadmill or they stress their heart with adenosine, Wtrex, persantine to stress the heart to see if they have changes in their EKG or if they develop chest pain, to diagnose ischemia of the heart before they have a heart attack. So the procedure, it will kind of get a patient to have ischemia. We have that documented, and then we can intervene with surgery, a stent, PCI, percutaneous coronary intervention. So we can do all that. So they're going to have an EKG on. They're told to stop certain cardiac drugs, and it just depends on what they're using. So you'll have a paper, and they'll tell you which ones to stop, or you can look it up on the computer. Avoid smoking or drinking alcohol beverages on the day of the test, and eat a light meal. And then what they do is they, like I said, stress the heart, and they are going to stop for one of 3 reasons. A predetermined heart rate is reached and maintained. Patient has those signs like they're having chest pain or their blood pressure drops or they start throwing PVCs, then they'll stop it. Or if they have a depressed ST segment, which indicates ischemia. So they stop it when they've reached the level or they have abnormal manifestation. Okay, so the scan is where they actually will inject radiopaque tracing material, and then they'll put them through some films, and what they're looking for basically is if there's any cold spots in the heart that would indicate there's areas of ischemia or infarction in the heart. Okay. Then we talked about the treadmill already, and they can use persantine, Wtrex, or adenosine. They can use any one of those. Okay, so cardiac cath. Cardiac cath is a lot more invasive, so you want to think of that. And they can do it on the right or left side. Probably the most frequently done is the left side of the heart. because that's where a lot of the pathology goes on, is on the left side of the heart. So that's typically the side that we see when we have a cardiac cath. When we go into the left side, we have to go through the arterial system, so there's a lot more complications, as you'll see as we go on. Okay, so it's either entered, if it's right side, it goes into a vein. If it's left side, it goes into the artery. They're using the brachial artery these days too. I think there's less complications than with the femoral. When the dye is injected, the patient does feel kind of warm sensation. It kind of feels like you're peeing your pants. So they have that warm sensation. So pre-procedure, informed consent. Make sure they're ready for the procedure. We show them a video, make sure that they know what's going to happen. The nurse will review the purpose of the procedure and inform them how long it will take, and that they'll feel that warm sensation, so they're ready, that people will be monitoring them very, very closely, that ask if they have allergy iodine. Now, some of the newer dyes are not iodine based, but you still ask that. And make sure that they have held some of their meds, specifically DIG or diuretics, before the procedure. And then what we're going to do is we're going to just, after the procedure, they typically will they can use a plug these days, a product that will kind of heal off that area at the site so it doesn't leak or they don't bleed out. But you want to always check the peripheral pulses. The pulse is peripheral to that. So you're always checking the peripheral pulses, and make sure the skin's warm and dry. They're not in any dysrhythmia. You're going to want to monitor shortness of breath and bleeding. And then at the leg, some sandbags aren't used as much anymore because they have those plugs that they can use. The legs should be straight if it's a femoral entry, and they should be flat for 6 to 8 hours. Watch them for pain and treat any of the side effects. Now, I mentioned that with cardiac catheterizations, the side effects are so much more concerning after a left-sided cardiac cath than after a right side. And here you see that with right-sided, they get things like thrombophlebitis, maybe a pulmonary embolism. That sounds pretty bad, but a vagal response. But on the left side, you could have a MI, a stroke, an arterial bleed. So see how more concerning those are. So if you want to see those, I put the page number in there. I'm hoping it's right. So the page number is listed there for you. So myocardial infarction pathophysiology. So when we're talking about what happens, the coronary vessel becomes obstructed, and it's a complicated lesion that occurs in there that develops, and then it usually will develop a thrombus that completely occludes that vessel that leads to it. So when we're thinking about what happens, oxygen is deprived, and then there's areas that are really like necrotic and infarcted. So there's different zones. We'll look at that in just a minute. Usually about 35 to 45 minutes of ischemia will produce damage to part of the myocardium. Our role is to prevent a large portion of damage to the myocardium. So that's something to think about. There are some videos on YouTube. I think they're still active. If not, they were just on pathophysiology. So when we're thinking about what happens, if you have collateral circulation, that can take over. So that certainly can take over and help the patient. The heart's ability to regain or maintain depends on the location and the size of the infarct, and the body's cell response is the inflammatory. So they get some systemic inflammatory response as well after a myocardial infarction. So going on, here's a picture of that complicated lesion So you can see that, and you can see the fatty streak building, and then the area growing with fibrous plaque, and then the thrombus developing. So there's that pathophysiology for you. There, like I said, there's different zones that occur of injury. There's a zone of necrosis. There's a zone of, well, I'll show you in just a minute. I think it's easier when I show you a picture. A zone of ischemia, and I'll show you. Okay. Then there's different types of MIs. There's a ST segment elevation MI, and that's just where anytime the ST segment's elevated, it's called a STEMI. And then there's also a non-STEMI. So a non-STEMI would be one where, you know, they still have had damage to the heart, but it hasn't impacted the ST segment. They can call MIs according to the area of the heart that's affected. So anterior, inferior, posterior, lateral, and the transmural is that Q wave MI that I talked about earlier. So when I'm talking about zones of injury, in this picture, you can see on the very end that there's an area of necrosis. And then the next area is just injured, and then ischemia. We say time is muscle because we want to protect, we want to save these two zones. We want to save this zone and this zone so that the patient doesn't have a permanent large area of damage. Okay, so that's what we're going to try to do, is decrease the area that's affected. So down here, it just kind of gives you, this is a T-wave inversion, okay? See that in ischemia too. Here's the actual injury or infarcted area. You can see the ST segment's elevated. We draw a line over here. The ST segment is elevated. And then here's our abnormal Q wave, okay, where this is dead over here. And a great big ST segment elevation there too, huh? So what I want you to remember about that is ST segment elevation equals an MI, and ST segment depression is typically seen in ischemia. So if you draw a line across here, there's no ST segment elevation on this one. We come down here, we draw a line across here, across through the P wave along this line, isoelectric line. This is above it, so this is ST segment elevation. We come down here, we draw the same line, and this is below it, so this would be ischemia because there's ST segment depression. All right, so typically what happens with a myocardial infarction is that the heart, after infarction, 6 hours after infarction, the region becomes blue and swollen. Then after 48 hours of the infarct, it turns gray and yellow. And then 8 to 10 days, it really is kind of very weak in that area, so that they could have a rupture at that point because the edges haven't really formed enough granulation tissue to support it. And then eventually what happens is a scar tissue occurs, or ventricular modeling, as we call it. So ventricular remodeling. And we'll talk about that a little with some of the medications we're going to give. We talked about that picture already, so I'm going to skip. Skipping. So anyway, on this slide, you can see left anterior descending is a main focus of a lot of MIs, and anterior wall is 25%, so it's pretty high. And then you have your posterior wall MIs. You can have your right coronary artery, which is the inferior wall MI, 17% of the time. So those are some just information on how much they occur. And then obstruction of the left anterior descent. I think we already said this, so I think I've said this already, so I'm going to skip past that slide. It looks like it's repetitive. So how do we know that patient's having an MI versus just angina? Well, first we know because the patient's going to be experiencing chest pain for a longer and more intense intensity of the pain. So longer and more intense. And remember that different patients manifest differently. They can radiate down the arm, the neck, the jaw, the teeth. And then women can even radiate down the right arm, and it could just be shoulder pain. So women tend to manifest a little more atypically than men. It's crushing. Sometimes they feel like an elephant sitting on their chest. And then they also have associated symptoms. So associated symptoms include like shortness of breath, nausea, vomiting, tachycardia. So those things that come along with the actual event that aren't necessarily, just one second, I got it. Necessarily, sorry, I didn't want to make a lot of noise, but I needed to grab something real quick. So, chest pain, but they're, in addition, dysrhythmias, anxiety. So those are associated symptoms we see with a myocardial infarction. Ashen skin color, cool, clammy, those types of things. Now again, I put all these diagrams in, and I know not everyone likes these. It just really depends on how you best learn. But if you don't like it, you don't have to use it. But really what this shows is everything that we would do to care for a patient with a myocardial infarction. And I'll point some of them out for you. So you all know Mona. So there's our aspirin. So if we got that going. On this side, we're going to think about some thrombolytic therapy. So we'll talk a little bit more about that. The nitrates to keep the coronary vessels dilated. Beta blockers may be used in order to dilate and help with coronary blood vessels. Oxygen always, right? That's your O in Mona. And then nitrates again down here. If they have increased afterload, there's vasoconstriction. They may need some vasodilators. We come over here. These are the diagnostic tests. Antidysrhythmics, angiotensin receptor blockers. We're going to see in just a minute that they're going to really help our patient prevent that remodeling or scarring of the heart, so they don't have as much end cardiac output loss or contractility loss of the heart. Okay, so Mona greets all patients, you know that. And it's not in the order that it is. It's not morphine, oxygen, nitroglycerin, aspirin. Okay, what would you do first? Of course, you'd put the oxygen on first, right? Okay, so if you want to reword her name so it's in order of what you do, feel free. Cardiac arrest sometimes occurs, so we may have to do some CPR, administer drugs, and oxygen. We already said that up top, so we got that covered. And then PTCA. PTCA is also referred to as PCI. So if you want to just write PCI down next to that, that is a percutaneous coronary intervention. And in that situation, they will put, they do it just like a heart cath, but they have a balloon and a stent on the end of the catheter that goes in, and they inflate the balloon once they're in the area that's obstructed, and then they will push the plaque against the wall and then leave the actual stent in there. CABG is coronary artery bypass graft. I didn't know what that was when I first graduated, so there you go. Now you know. And AAA isn't insurance. It's actually an abdominal aortic aneurysm. So that's important to know too. So PTCA, again, aka PCI, so you may see that. So it's a scenario where they actually are going to go in and they're going to try to get that coronary artery reopened. They can do it within 70 minutes of the onset of the chest discomfort. So really encourage patients to get in early, because if they don't, then that option is gone off the table. So they can do a single or double vessel in that process. And they can use the glycoprotein 2A, 3A inhibitors or thrombolytics in addition. We'll be talking about those next. Okay, so they inflate the balloon, and then they pull the balloon out if they're not going to leave the stent. But anymore today, they leave the stent, and that, just like in our stent that is in the vena cava, is impregnated with heparin so that clots don't develop on it. Now, cabbage. Cabbage used to be the mainstay treatment, and it's becoming minimally invasive, so there's been changes. When I first graduated, that was 6 weeks after I graduated, I started taking open heart surgeries. And so they were some of my favorite patients because they did get better quite quickly. But it is quite the responsibility to care for a patient in the case that they're in at the time. So what they do or can do, and again, they're becoming more minimally invasive. This is a heart-lung machine that they hook up, and there's usually 2 people running the heart-lung machine if the patient has to be put on that. Now, with the minimally invasive, they're not using the heart-lung machine as much. So but they may still need to use it in some cases. Then what they do is they either take the greater saphenous vein or the internal mammary artery, and they're going to take it and put it above the area of the occlusion at one end, and the other end below the area of the occlusion to bypass the area that's occluded and provide blood to that area to reverse the effects. Now, this is what a patient looks like when they come back from an open heart surgery, and I always teased when I was doing this that they had something in every orifice, and if they didn't, we created a new one to put it in. These patients have more lines than you have ever seen in a patient in your life. They have a nasogastric tube, endotracheal tube, pulmonary artery catheter, which is right here. They have 2 mediastinal chest tubes. They have then also a pleural chest tube. They have epicardial pacing electrodes that are in just in case they're needed. They have, they'll be monitored for their SaO2, a catheter, an arterial line, and then they also will have, when they get back, we used to put in a rectal catheter or probe to monitor more of a core temperature. And yeah, I think that's about it. I don't think there's anywhere else we can put anything. They got enough stuff in them, don't they? So anyway, some of the meds, if they don't do surgery, some of the meds that they're going to use, they can use anticoagulants and thrombolytics. Remember, anytime we give a patient a thrombolytic, they automatically have to be put on anticoagulant as well, so they're at bleeding concerns. So streptokinase, activase are some of the names, and those are usually given within 30 to 60 minutes of the onset. Okay, so they want to get those in really, really soon after the onset of the chest pain. Heparin can be used, Coumadin. Antidysrhythmics, probably the most common, amiodarone, digoxin, beta blockers as well. So atenolol, tenormin is the choice for a patient with a myocardial infarction. Remember I said the ACE inhibitors are going to prevent remodeling of the heart, so that would be given. And calcium channel blockers such as ditilazam or cardizem to dilate coronary blood vessels are given. Now I said I'd get back to glycoprotein 2A, 3A inhibitors. And these actually are like platelet, they attack the platelets, so components of the platelets, and hopefully decrease the size of the thrombus, and so the thrombus can't continue to grow. So these meds can be used as adjunctive therapy to both PTCA or PCI, and it can also be used in a case where you have a patient undergoing what is it? Cardiac cath, or yeah. Nitroglycerin will decrease coronary workflow, and it's usually given IV in a patient with an MI. And then vasopressors if they're in shock. If they're not, no. Stool softeners, because we don't want them to Valsalva, because that stresses the heart, and we don't want that. Morphine is the pain drug of choice, and it does help increase dilatation of the coronary arteries as well. And then Plavix can be given as well. So, so when we're talking about treatment and nursing interventions of an MI, just closely monitoring them, monitoring their cardiac function, their rhythm, also looking at the monitor, their hemodynamic monitoring for their right-sided pressures, left-sided pressures, intra-arterial pressures as well. Anticipate pacemaker insertion, and that usually something, if they go to surgery, they'll have that the wires in, so you could access that if you need it. Monitor their pain for comfort. Administer analgesics. Observe and report changes of level of consciousness, pallor, pressure, blood pressure, of course, tachycardia. And probably the biggest complications I saw when I had patients with MIs are dysrhythmias and heart failure. If they had a massive MI, then they would develop heart failure and cardiogenic shock. It didn't sound right all of a sudden to me. They're going to have TED hose on. Again, stool softeners we talked about, making sure they don't Valsalva. They can usually, we'll let them get on a commode versus a bedpan. Prescribe diet and advance slowly. So that's something that you do. Maintain I&O and provide emotional support for the patient and the family. Patient teaching, a couple things that you want to keep in mind. You know, a lot of patients are males that have MIs, and when they can return to sexual activity, maybe for some women too. But anyways, usually 7 to 10 days, or they usually say when you can climb a flight, 2 flights of stairs without any signs of chest pain is a time that you can resume sexual activity. And just what they need to report to their doctor is going to be important. Okay, 2 more things and I'm done. So a AAA is where there's an aneurysm or outpouching of the aorta. The most common one we see is in the abdomen. They can occur on the ascending aorta, but typically they occur, most of them that we care for are in the abdomen. So they may complain of abdominal pain, or they may notice a pulsation outside of midline. Main concern is we have to treat it before it ruptures. Both my dad and my grandpa both had aortic aneurysms, and it actually killed my grandpa. My dad died of cancer, but my grandpa died of a rupture of his aneurysms. So when we're talking about that, abdominal is like lower thorax. My brother has one right now. It's very genetically, it occurs very much through genetics. So my brother has one sitting on his ascending aorta, and so they're just watching that right now for any changes in like pain, location of pain, any shortness of breath, anything like that. So when they diagnose it, x-ray, they can see an eggshell type appearance around the aorta. They can do a CT scan or arteriography and ultrasonography. And basically, it's a watching game. My dad's was like 5 centimeters for years. My brother's is sitting at 4.5 right now. And they just kind of watch it until it gets to the point where it's greater than 7 centimeters. And once it's greater than 7 centimeters, then they consider operating. So preoperative, they're doing these minimally invasive. When my dad had his surgery, they opened his abdomen and had to go in, and they actually put like graft in there to bypass the area that is in the area that it has the aneurysm. And then postoperative vital signs, making sure with this and cardiac surgery at CABG, you don't want the blood pressure too high. We always had our patients on nitrite because if it got too high, then our patient would rupture their grafts. So you got to protect the grafts, watch them for complications, bleeding, tissue perfusion to the end area, which would be like the kidney function, the feet, to make sure they have good pulsations, make sure they don't have any dysrhythmias, respiratory distress. And like I said, anymore they're becoming more minimally invasive with that. And it's less recovery time for the patient as well. And then they can also have them in the peripheral arteries, but I'm not going to hold you responsible for that. Aortic dissection is where there's actually a tearing of the aortic, the layers of the aorta, and they bleed into it. This is what I was telling you that a friend that I have recently had and almost died from. They feel like it's a pain that feels like tearing, ripping, stabbing type pain. Here's some examples. I went out and just found some. See, they bled all the way around this, around the aorta. Here it was more of an ascending one, so they bled in this area, which will compress the heart and cause cardiac tamponade. This one's over here, and that's what it looks like post-mortem. Pretty gross, isn't it? So dissection, you know, what they did with the fella I know, they got him in an air ambulance and they flew him, you know, right away to a major trauma 1 type center, and luckily he survived. So a couple of things that you want to keep in mind about abdominal aortic aneurysms is you don't want to do a lot of deep palpation of those. Not advisable. I don't think they would rupture, but then it's always about end perfusion of the distal areas, making sure that that's adequate. So looking at that, then surgical repair, you may have a patient, you know, they go to ICU typically, so they don't go to the floor. So you're probably not going to have them as a new grad, but as you go on, you may. So watching them for cardiac output and those types of things, bleeding. Well, we're to our last topic, and this one's going to be short and sweet as well, because as I told you earlier, I'm not going to have you learning about all the hemodynamic monitoring. The two that I'm going to have you learn about are the non-invasive blood pressure, and then the jugular vein distension. Nope, those aren't the two. Non-invasive modalities, and then intra-arterial monitor. So those are the ones we're going to talk about today. And I'll just mention what the others do again, just so you have it, okay? So here we go. So you do hemodynamic monitoring all the time when you take a blood pressure or you check jugular vein distension. You do it all the time. What we're talking about is more invasive ways of doing that. Okay, so we're going to get a little more invasive. We can also look at serum lactate levels, which we just did with our septic shock. So here we go. Back in the day, I'm going to age myself again. This is what we used to do to measure central venous pressure or jugular vein distension. We don't do that anymore, do we? We just kind of eyeball it and see if it's, if we can see any distension at 30 degrees. So hemodynamic monitoring, there's 3 distinct types of hemodynamic monitoring. There is intra-arterial, that's one we're going to focus on. Then there's a right atrial or right-sided pressure, and then a pulmonary artery pressure, which is a left-sided pressure. So really, that's all I want you to know, is that the left arterial pressure is going to measure pressures in the left side of the heart, and the right arterial is going to measure central venous pressure. Okay? So here's all the stuff that you would have to gather if you're caring for a patient with hemodynamic monitoring. Now what we have here is an IV bag, and it's usually a 500 bag of normal saline and heparin. And sometimes, even today, some places don't use heparin, but it would just be a small amount of heparin, like 500 units. We pump this bag up to 300 millimeters of mercury, and then this will indicate when you see 300 millimeters of mercury, you stop pumping. That 300 millimeters of mercury is going to provide 3 milliliters an hour of the solution to go into whatever, the artery for our sake here, and it's going to prevent any complications of bleeding out, because we're in an artery now, so we can't just put a line in it and expect them not to bleed out. So we have to counter pressure it. The tubing also has to be stiff. This tubing here is stiff because if it was soft, like most of the tubing is, then it would alter our pressures. Here just shows 3 distinct lines. So this is a pulmonary artery catheter, which you don't have to know. The only thing we're going to focus on here is the arterial line. So the arterial line goes into the patient's radial artery, monitors the patient's arterial pressure. Okay? So we're going to focus just on that arterial line, and with it, no matter which one we do, we're going to do the arterial line. You need that pressure bag, okay, and then that heparin in it. You also will have a display on the monitor which shows you a waveform, pressure values, and then you will also have a number that pops up, like a blood pressure. So it'd be like 90/50 or whatever. Transducer is what converts that to electrical signal, and amplifier allows for that to be displayed through the cable. So in order to be accurate with your arterial pressure monitor, it always has to be level with the phlebostatic axis, which is the 4th intercostal mid-axillary line. Okay, so that's something you need to know for NCLEX. I don't know why they want you to know that, but they do want you to know that. What is your phlebostatic axis? It's the 4th intercostal mid-axillary line. Okay, and that's approximately at the level of the right atrium. Just like the scale that you stand on in the morning, you want to zero it, make sure you don't weigh too much. Same thing is true with these. We have to zero them before we take a reading. So we zero them out. And you don't need to know how to do that. Here's your phlebostatic axis marked on a patient, and we always mark them. They have a little X, is where we level the transducer to. So with this arterial pressure line, radial artery is the most common, and then just like we talked about with the ABGs, we're going to need to do an Allen's test prior to make sure that we are where we should be and that there's collateral circulation so the patient doesn't have ischemia to the hand. The brachial artery can be used as well. Now this is the monitor. This is the peak, so this would be the systolic. This is the dichrotic notch. So that's a dichrotic notch. And you don't need to know a lot of this, but it's just what it looks like, and it'll read out a blood pressure. I think the most important thing to know about that is if it doesn't look big like this, then it could be the catheter's up against the wall, or it's not working right, and you just have to flush it. So there's the equipment again, and if you want to see someone putting in an art line, there's a link for you. And so we do this, like if I had a patient that needed to be on dopamine, dobutamine, or Levophed, we'd use this. If we need to do a lot of frequent diagnostics because they're unstable, we'd use this. And low flow state, so they're in shock that we talked about. and just in severe like hypertension. So complications include thrombus, embolus, hemorrhage, okay, infection. So those are some of the complications we have. And as a nurse, we're watching, that's when I said the waveform doesn't look big, that's called a dampened waveform. We're looking for that. We're making sure that the patient never ever bleeds out of one of these. I had someone tell me once that there was a patient in a facility who had a central line, and they sat him in the chair, and behind the chair, they put the IV tubing, and what happened is it came disconnected behind the chair and the patient bled out. No one knew it. So you always want those within eyesight. Set alarms.